This lecture will discuss care of patients with disorders of the red blood cells. Anemia is a condition where there is a deficiency of red blood cells, hemoglobin, or both in the circulating blood. Because hemoglobin carries oxygen, this results in a reduced capacity to deliver oxygen to the tissues. So if you think about what we talk about, the triad here, delivering oxygen to the tissues, what do you need? You need oxygen to come into your body in the respiratory system. You need hemoglobin in your circulatory system or hematologic system to carry the oxygen, and then you need a cardiovascular system that functions well to circulate the blood. So this is one of the big three that can affect oxygen delivery to your tissues. Symptoms such as weakness and dyspnea often lead the patient to seek medical attention. They usually don't know they're anemic. They rely on those symptoms to let them know that they are bleeding or that they've got some sort of a iron deficiency. There are three kinds of anemia that are generally recognized, or three, I don't want to say kinds of anemia, three general classes of anemia. One is blood loss, one is impaired cell production, and one is increased cell destruction. There are the three big categories for the etiology of anemia. You either have fewer red blood cells or lower hemoglobin, and this can result from blood loss, either a massive one-time loss after a trauma or a surgery, or a slow chronic loss, as can happen with a bleeding ulcer or colorectal cancer. Anemia can also result from a failure in blood cell production, which can result in either fewer cells or low hemoglobin. One type of that would be iron deficiency anemia, or folic acid deficiency, or vitamin B12 deficiency. Another way that you can have a problem with red blood cell production is if you have abnormal bone marrow function, as in aplastic anemia, or another disease that keeps the stem cells in the marrow from producing mature red blood cells as they should. Then there's anemia that's associated with an excessive destruction of the red blood cells, or hemolytic anemia. This can be genetic, as in sickle cell or thalassemia. This can be from different poisons that people encounter, or from drugs that people take therapeutically, such as different diuretics or antiarrhythmics. It can also be an autoimmune response. And these things all result in fewer red blood cells because of a destruction of the red blood cells. This concept map on the pathophysiology of anemia is taken from your book. It looks at the three different categories of etiologies for anemia: increased blood loss, increased destruction of red blood cells, or decreased production of red blood cells. All three of these lead to a decreased oxygen carrying ability of the blood. And remember, the goal here is to deliver oxygen to the tissues. And so anytime you have a decrease in your red cells or in the hemoglobin carrying capacity of those red cells, you decrease the oxygen carrying capacity of your blood. This can lead to tissue hypoxia, and then you get your signs and symptoms, which are pallor, fatigue, headache, dizziness, faintness, those sorts of things. So I just gotta keep hammering this in. Oxygen delivery is ventilation, getting oxygen in, transportation, moving the oxygen around, and perfusion, getting the oxygen to the tissues with the circulatory system. The transport function is a hematologic system. Anemia is decreased transport. If gets worse if problems exist with ventilation or perfusion, because then you have a decreased ability to compensate. So therefore, if you have somebody who has COPD or congestive heart failure, anemia is a much bigger problem, because the other systems have a decreased ability to compensate. People who might be at risk for iron deficiency anemia include people who have a decreased intake. And dietary choices, of course, people who don't eat a lot of iron-rich foods, this could be for a number of reasons. It could be personal preference, or it could have to do with socioeconomic factors. I want you to think about the social determinants of health here. Do people have the money to buy food? Do they have access to food in their neighborhood? Do they have transportation to get food? Lots of different reasons why people don't get the iron-rich foods they need in their diets besides just personal preference. Also, there's poor absorption, people with iron malabsorption problems, chronic diarrhea, partial or total gastrectomy, celiac disease, that sort of thing. People then may have increased iron requirements, such as infants or children who are growing very rapidly, and also pregnant women who have a rapidly growing child inside them. Then finally, there are those who have chronic blood loss. Menstruation could be considered chronic blood loss, and for the most part, you don't lose that much blood normally, but there are people who do lose a lot of blood for various reasons, fibroids and other reasons where menstrual flow is much greater than the normal person's would be. You can also have occult GI bleeding that occurs with ulcers or with colorectal cancer, and then of course other kinds of cancer are responsible for chronic blood loss as well. Anemia is categorized into mild, moderate, and severe depending on the hemoglobin level. So a mild anemia would be 9.5 to 13, a moderate 6 to 10, and a severe less than 6. And when you have symptoms, these symptoms are from the decreased ability to transport oxygen to the tissues. This table lists the clinical manifestations of anemia and when they occur in either a mild case, a moderate case, or a severe case. Again, severe being a hemoglobin of less than 6. As you can see with mild anemia, there's not a lot happening. You may get some palpitations, some dyspnea on exertion, might be a little tired, but for the most part, it's a very, you could attribute these symptoms to something else. Then when you get to the category of moderate anemia, a little bit more palpitations, maybe some increased dyspnea, definitely some fatigue going on. But again, you could attribute these to something else. Until you get severe anemia, you don't see the pallor, the tongue symptoms, the tachypnea, orthopnea, dyspnea at rest. You don't get the headaches, the impaired thought processes, confusion that you see in older adults. You just don't see those until the anemia is pretty bad. So it can sneak up on you. The treatment of anemia consists of treating the underlying problem. So if you need to build replacement cells, you need supplements for what you're missing. So iron supplements, vitamin B12 supplements, folic acid supplements. You only transfuse somebody if absolutely necessary. The nursing management of anemia always begins with a focus assessment. You always want to consider anemia a possibility when you have somebody who presents with fatigue, headaches, and dyspnea. And then you also want to consider vitamin B12 deficiency with dementia. In terms of health history, you want to look for blood loss, which they may or may not be aware of, any kind of GI disease such as a gastric ulcer, change in appetite or weight, what supplements do they take, changes in urine or stool bowel habits, have they had radiation or chemotherapy, what is their genetic or cultural history, do they complain of headaches, dizziness, any visual changes? Are they having pain anywhere? Any itching, palpitations? And fatigue or dyspnea are really huge historical things here, as well as are they cold sensitive? If you look at the physical exam, their skin will be pale if they are light-skinned. If they are dark-skinned, more likely their mucous membranes and their conjunctiva will be pale. Their sclera can be yellow if there's jaundice present. Lips can be cracked. Nails can have that brittle spoon shape that we saw in the picture in the assessment series above here. And also hair can be thinning. Respiratory-wise, tachypnea, orthopnea if it's severe, dyspnea on exertion with mild to moderate anemia, and at rest with severe anemia. Cardiovascular, tachycardia. Sometimes you can get a systolic murmur with severe anemia, even angina, and sometimes ankle edema. GI, stomatitis, and that beefy red tongue. You can get abdominal distension and an enlarged liver or spleen if you have a hemolytic anemia going on. And then neurologic headache, of course, dizziness, decreased level of consciousness, especially in older adults. They can be irritable, ataxic, and they can also have paresthesias, numbness and tingling in their extremities. The nursing diagnoses here. depend a little bit on the kind of anemia, but some of them go across all different kinds of anemias. Activity intolerance and impaired gas exchange if you have severe anemia, inadequate nutrition, and I want you to think about, again, those social determinants of health to determine whether or not this is by choice or because they don't have a choice in the nutrition. Risk for falls because of weakness, dizziness, fatigue, and impaired oral mucous membranes. The next couple of slides have examples of expected outcomes that you could write. This one is within a month, the patient will be able to perform hygiene, dressing, and grooming without needing to rest between activities. This, of course, would have to do with the dyspnea on exertion. Within 2 months, they will be able to carry out usual daily activities without shortness of breath or fatigue. So these are progressive goals that you were looking at with the patient. Couple of other outcomes here. Patient will eat 3 nutritious meals daily containing sufficient iron, folic acid, vitamin C, and protein. Verbalize understanding of the dietary and medication regimen within 1 week. Remain safe from injuries related to falls, and will have intact oral mucous membranes. These are all possibilities of outcomes that you could use for a care plan if you were writing one on anemia. Interventions are based on the particular kind of anemia that is affecting the patient. This includes medical interventions as well as nursing interventions. For people with anemia severe enough to cause fatigue, of course, assisting with their activities of daily living and providing planned rest periods, clustering care, those sorts of things are important, and also teaching them and working with the family to get them help at home will be important here. As far as nutrition goes, not only education, but they may require some financial or social assistance. So a consult to a social worker may be an appropriate intervention for someone who is in need of some nutritional interventions. When you are giving iron supplements, you need to remember that iron supplements should be taken an hour before or 2 hours after a meal so they don't cause GI distress. Antacids and many other drugs interfere with iron absorption, so think about what you're giving them with, and also milk interferes with iron absorption, so you never want to give them with milk. Vitamin C can assist with iron absorption, and so things that contain vitamin C, orange juice, grapefruit juice, anything with ascorbic acid in it can be given with the iron and will facilitate the absorption of that iron. Vitamin B12 and folic acid are supplements that you can give, and you really anything you give, of course, you want to check to determine drug interactions, but there are a lot of things that interfere with iron absorption, and also constipation is a side effect of iron supplements. And so one thing that you want to think of is not just what foods have iron in them, but what foods do they need to eat, the vitamin C foods, for instance, and also the foods that they need to eat to increase the fiber so that they don't get constipated. So there's a whole lot of nutritional stuff here that doesn't just have to do with what has iron in it, but what facilitates the absorption and what prevents constipation. You want to monitor for the desired effects. So is their energy increasing? Are they able to do more? Are their mucous membranes and conjunctiva pinking up? Are their labs getting better? And then educating people about how to prevent what happened in the first place. Sometimes it can be as easy as the needed dietary adjustments. Other times it has to do with more medical monitoring, depending on what the cause is. When you think about older adults, you might want to think about something that they call the anemia of chronic disease. It's often mistaken for iron deficiency anemia. And the reason I bring this up now is because older adults tend to have more chronic illness than their younger counterparts do. So in this case, anemia is a symptom that's brought on by an underlying medical condition that causes either altered iron metabolism, deficiency of erythropoietin, or shortens the lifespan of red blood cells. Usually, hematocrit and hemoglobin levels should remain unchanged in healthy older adults. But there is about a 20% incidence of anemia among older adults, and this is most often caused by poor nutrition. Talked about that quite a bit, so I won't continue on there. Blood loss from chronic illness is also a cause of anemia in this population, and so these are the people who, when they come in for their annual check, are the people that probably ought to have an H&H drawn just to check and make sure nothing big's going on. And if you think about it, they are also the people who are more likely to have some sort of chronic respiratory or chronic cardiovascular thing going on, which can be an even bigger problem if indeed they do become anemic. We've danced around vitamin B12 deficiency just a little bit, but let's talk now specifically about the pathophysiology of pernicious anemia. What happens in pernicious anemia is when you ingest B12 in your food, you need intrinsic factor in order to absorb that. In pernicious anemia, your stomach lacks intrinsic factor due to an antibody reaction, and so therefore you don't get B12 absorption in your small intestine. The B12 is excreted, and this lack of B12 then causes the bone marrow to produce abnormal erythrocytes that don't function normally. So it continues to produce the red blood cells, they are just abnormal. And this is pernicious anemia. Another thing besides an antibody reaction that can cause this is if you have somebody who's had gastric bypass surgery or a gastrectomy, there's a risk of pernicious anemia because there will be a decrease in the available amount of intrinsic factor, which is of course produced in the stomach. So you always want to be on the lookout for pernicious anemia in these people. The diagnosis is made with a CBC and then red blood cell indices, and what you get here is a macrocytic or an unusually large red blood cell. So pernicious anemia is a macrocytic anemia. For treatment, you get B12 injections. Taking oral B12 won't work here because you're not going to absorb it. Or intranasal B12 is also something that is used so that you don't have to have the injections. Used to be home health nurses would go around and give B12 injections, or people would have to come into the office to get a B12 injection, and now you can just do it intranasally, and people can do it on their own. Folic acid, they also give for this, and it's a lifetime therapy that is needed here. Aplastic anemia is another kind of anemia that results from a problem in the bone marrow because of toxic drugs or chemicals, sometimes radiation used in treatment for chemotherapy, sometimes being on cardiopulmonary bypass. There are bacterial viral illnesses, TB, hepatitis, lupus, and autoimmune disease. All of these things have been known to be responsible for aplastic anemia. So what happens is, because of all this, the bone marrow becomes incapable of producing the numbers of cells needed. Aplastic literally means not developing, so the bone marrow does not produce cells. This can also be congenital, by the way. So you have your bone marrow that's damaged. It can't produce any of the cell lines, so it can't produce erythrocytes, leukocytes, or platelets. So you get anemia, neutropenia, thrombocytopenia, and you can also call this pancytopenia. Everything is decreased, which leads, of course, to infection and bleeding, and if it's left untreated, this can be fatal. The diagnosis of aplastic anemia is made with a CBC, excuse me, and a bone marrow aspiration and biopsy. The treatment varies with the severity of the bone marrow failure and depends on, of course, the severity of the pancytopenia, what your symptoms are. Anemia, clotting, infections, those are all problems that you get with aplastic anemia. So really the big deal is early identification and treatment of the underlying problem, because this is caused by something. It is often difficult to find the cause, and even once you do, you can't undo the damage. So you need aggressive support measures to prevent bleeding, to prevent infection. Transfusions are appropriate here, immunosuppression if indeed it's an autoimmune thing, steroids, colony stimulating factors to try to get the bone marrow up and running again. Really, a bone marrow transplant is the most effective treatment. The health promotion message here is that as nurses, we should promote public education about the dangers of toxic chemicals. So people really need to read and follow the label instructions on cleaning agents, insecticides, all chemical compounds to keep something like aplastic anemia from happening to them. Sickle cell disease is an inherited disease. It is autosomal recessive, which means that you can either be a carrier, or if you have both of the genes, then you will have the disease. In the U.S., people of African or Eastern Mediterranean descent have an increased incidence. Worldwide, people in Asia, the Middle East, the Caribbean, and Central America also have an increased incidence. 10% of African Americans have this trait, which means they're carriers. It doesn't mean that they have the disease, it means they're carriers. What happens is that the red blood cells have this mutation that makes the hemoglobin in the red cells sensitive to changes in oxygen. So any decrease in oxygen that happens from exercise or anything that you do, the cells change from spheres to little crescent shapes, and they become very rigid and are easily cracked or broken. This shape causes them to get tangled and stuck in blood vessels and organs, and this results in congestion, clumping, clotting. It also makes for a decreased cell lifespan. So normally, if you recall, the lifespan of a red blood cell is 120 days. The lifespan of a sickled cell is 10 to 20 days. Hence the term sickle cell anemia, because you have less circulating functional cells with hemoglobin that works. These broken cells the contents get dumped into the blood, and then because of the hemolysis, you get an increase in the bilirubin, which causes jaundice and gallstones. Because of the increased bile pigments, you get an enlarged liver and spleen because of the increased products of hemolysis. These sickling changes are a daily occurrence, and the process can be reversed when the oxygen level returns to normal. However, occasionally the changes don't reverse, and that's when you have a sickle cell crisis. The blood then collects in capillaries and veins of the chest, the abdominal organs, the joints, the bones. They can cause necrosis, and it can also cause pain, fever, and swelling. The big thing about sickle cell crisis is excruciating pain. If you look at this diagram, it can give you a little bit of an idea of what the changes in the red blood cells look like. So you have a normal cell with hemoglobin A, and when it becomes comes in contact with the low oxygens in the tissues, it retains its shape. If you have a cell with hemoglobin S, it sickles. They clump together and include small blood vessels when they are in conditions of low tissue oxygen concentration. Signs and symptoms of sickle cell disease, as I mentioned, are intense pain, and then whatever symptoms of clogged vessels and organs, wherever the cells are clumping, that will be where the pain is, and maybe swelling or whatever in those particular areas. Swelling in the joints, elbows and knees particularly, abdominal pain if you have an enlarged liver or spleen where a lot of cells are collecting, or because of the hemolysis. Fever is present, an increased respiratory rate. Males can get priapism or priapism, I can't remember ever how to say that. Renal failure symptoms, because these little sickled cells can clog renal vessels. Really, any condition that leads to decreased oxygenation can cause a crisis. A really strenuous amount of exercise, infections such as pneumonia, sometimes exposure to cold, diabetic ketoacidosis, very stressful condition, anesthesia, and blood loss during surgery are things that can lead to a crisis, and also dehydration. A crisis can last anywhere from 4 to 6 days. They occur in cycles, and then they can go dormant for many years. And if you get repeated crises, you get chronic manifestations and changes in your joints, especially if you, in your hands and feet, they call that hand and foot syndrome. But it could really decrease your quality of life if you're having cyclic crises like this. The diagnosis of sickle cell disease, they do a smear of your red blood cells and do what they call a Sickledex test. I honestly don't know what it is, but it's somehow gets the cells to sickle in the lab. You can do hemoglobin electrophoresis and pherese out the S1 hemoglobin, and then of course on your CBC you'll have a decreased hemoglobin, decreased red blood cells, an increased sed rate because you've got inflammation, and an increased white blood cell count if indeed because of the inflammation. Treatment depends on what's going on. Depends on the severity and whether or not they're in crisis. Education is really important. Education in terms of making sure that your tissues are oxygenated, that you stay out of the cold, that you avoid infections, stay out of situations that will flip you over into crisis. Sometimes they do low-dose penicillin. In an acute crisis, hospitalization is required. They always get oxygen. IV fluids are important so that they can keep those cells moving in the vasculature. They'll sedate them and give them analgesia for the pain, and they can also do transfusions so that they can get normal cells in there. They also use chemotherapy called hydroxyurea, which is a chemo that sometimes they'll start in children, and it may decrease the crises. It's actually used in CML and ovarian cancer, melanoma, several different kinds of malignancies, but in sickle cell disease, for whatever reason, it decreases the amount of hemoglobin S. You can also do a bone transparent in very severe, bone marrow transplant in severe cases. On the last slide, I talked about education, and this is so important to prevent crises. Avoiding high altitudes, because it stands to reason if you are at a high altitude, there's less oxygen, and so the chance of your tissues becoming hypoxemic is greater. Avoiding vigorous exercise and iced liquids, anything that will make you cold, can cause your cells to sickle. Always maintaining adequate fluid intake, because remember, the sickling process is a daily occurrence, and so you want to keep from being dehydrated, keep those cells moving all the time. Smoking is an absolute no-no here. It is a vasoactive substance, and it will also cause local tissue hypoxemia, so just refraining from smoking is a very big deal for these people. Treating infections promptly is important, and adequate rest is also really important. When you are in a crisis, adequate pain relief is very important from a nursing standpoint. These people are in a lot of pain. Believe them and treat them. You want to monitor their intake and output, because as I mentioned earlier, these cells can get tangled up in your renal vasculature, and that can be a big problem. And also oxygen therapy. You want to make sure that they are really, really saturated. The hemoglobin, the good hemoglobin that they have, is really saturated, so you don't cause further sickling. Finally, a word about polycythemia. There are two types of polycythemia. Polycythemia vera, which is a genetic mutation, and it causes overproduced cells of all cell lines. So it's panmyelosis, or the increase in white cells, red cells, and platelets. Signs and symptoms are listed here. Dark flushed skin because of all of the blood cells there. Hypertension because your blood is so viscous. You can have vision changes, headaches, vertigo, tinnitus, all the stuff that's listed here. You get too many cells in the blood, it's very thick, organ congestion happens, hypervolemia happens, hyperviscosity, so you have engorgement of the vascular bed. You're at risk, high risk for thrombosis because of the thick platelet-rich blood. And the diagnosis, of course, would be a CBC and also bone marrow aspiration. They treat this with phlebotomy by taking some of the blood out, antineoplastic agents sometimes, and radiation therapy to decrease production in the bone marrow. You really want to increase fluid intake, 3 liters a day. For sure. Give them antiplatelet meds because they are at such high risk for thrombosis. Avoiding tight clothes, do not smoke, and also elevating the legs to facilitate venous return. The second type of polycythemia is secondary polycythemia, and this is something that you get from long-term hypoxia. It's a compensatory reaction, and you'll see this sometimes in people with COPD.